So, greetings. In this video, we'll talk about fluid therapy. How do we give patients fluids? So, remember we've talked about tonicity, which is effective osmolarity. If you're not sure before rushing into this, get an idea, go to anatomy and physiology. And tonicity and understanding it is really important. Okay. And why is it important? Again, this is a recap because it causes ECF to change the tonicity, which causes fluid shifts in and out of cell. Okay, we talked about plasma osmolarity. What is normal? 290. It runs between 280 to 300. And again, plasma osmolarity is the same as extracellular fluid osmolarity. Interstitial osmolarity equals intracellular osmolarity. Okay, so overall goal of this. First, we divide the fluids into whether they're hyper, hypo, or isotonic. Why is that? I gotta know, man, what they're gonna do when I give these fluids. Are they gonna move the fluid out of the cell or inside the cell or not gonna make a difference? And then the next question is, what are they used for? Okay. So let's start. So isotonic, they are the same as my plasma osmolarity. So my plasma osmolarity usually runs 280 to 300, and this is very close to where they're going to be. So again, I have three big ones: 5% dextrose, 0.9% sodium chloride, and lactates ringer. Okay, I abbreviate it as D5, NS, or 0.9 NS, and LR. Okay, again, we uh, use abbreviations. This is their osmolarity. Okay, the two that I think are important are dextrose and which is D5 and NS. D5 and NS, which is 250 for D5 and 310 for NS, normal saline. Okay, what are the big issues? D5, dextrose, it gives you free water. What does that mean? Well, the osmolarity is is isoosmolar effectively. However, when I give somebody sugar, it goes inside their body, C6H12O6 plus O2 gives CO2 plus H2O. So the sugar gets taken up by the cell and it gives people what? Water. And then I'm giving them water with this solution anyways. So they get water plus water. So the end product of giving dextrose is we're giving them water. Ah, something to think about. Okay, with sodium chloride, NS, causes acidosis, and this becomes remarkable when you give very high doses, very high volumes of normal saline. With lactates ringer, you are giving them, with each liter, you're giving them 4 milliequivalents of potassium. Okay, something to think about. Now, what does this, so just, I want to make sure the terms are clear. What does this zero point 0.9 sodium chloride mean? That means there's 0.9 grams of sodium chloride in 100 mLs of water. Okay, so tell me about D5. What does that mean? That means there's 5 grams of dextrose in 100 ml of water. Okay, something to remember. Okay, so when we do some mathematics, we're going to use this, but this way you'll have a good idea as well of what it is. Okay, so remember we talked about dextrose with osmolarity 250 and NS D5 to be 250 and NS to be 310. And this is where you're going to see the fun. Hypotonic solution, right? So this is going to be much lower than 280. So half normal saline, right? So what does normal saline have? 310. Half of it is 150, 150, 155 milliosmoles, right? 150 milliosmoles. So that's hypotonic solution. We can give hypertonic solution. For example, 3% sodium chloride, right? So 3% NS is called, so half sodium chloride, 0.45% of sodium chloride is half NS is what is abbreviated. We talk about hypertonic solution. So 3% of sodium chloride is called what? 3% NS. So NS, 0.9% NS has what? 310 milliosmoles. Well, I multiply this by 3, I'm going to get what? Around 930 milliosmoles approximately, right? That's hypertonic. What about D5.5 normal saline? It's hypertonic as well, so that's going to be 250 from dextrose plus half from of what? 310 from the half of normal saline. So that would give me what? 250 plus 155. It's about 405 milliosmoles, right? So this solution is what? 5% of dextrose that I mix in 100 ml. And I also mix what? 0.5 grams. So it's 5 grams of dextrose and 0.45 grams of salt that I mix in 100 ml. And that gives me what? 100 mLs of D5.5 normal saline, right? Perfect. So I've shared with you some common fluids. Now, can you be given some fluids different from the ones here? The answer is correct. You can't. So let me surprise you. What about 1/4 of normal saline? Is that hyper or hypotonic? Okay. So let's see. Normal saline is how much? 310. Normal saline is 310. So 1/4 of normal saline would be how many osms? Okay, around 77 osms, right? And normal osms are 280 to 300. So this is hypotonic solution. This is hypotonic solution. Excellent. So you guys see, even if I give you a curveball with some fluids, if you know a couple of values, you can pretty much guess what they are, right? Let's say I make up a solution. Uh, I'm going to make up something. I'm going to go D10 normal saline. I'm just making this up. So D10, so remember D5 would be how much? 250 milliosmoles. What about D10 would be 500 milliosmoles, right? And normal saline would be 310 milliosmoles. So it's 500 plus 310 is 810 osms, right? Normal is 280 over 300. This is a hypertonic solution. Okay, guys, see this? So you guys know some basic solutions, and even if I surprise you now, you guys can guess whether the solution is isotonic, hypotonic, or hypertonic. And you guys already know why that's important, right? Perfect. So why do I give fluids, right? So that's the next thing to look at, is now that I know fluids and what they can do, I need to know why I'm giving them fluids. There's essentially 5 reasons. There's 4 big reasons, and there's a 5th reason, which I'm going to add to it, which is what I call a special case. First, provide fluid volume. This is called volume resuscitation. Second, maintenance fluid. So in other words, compensate for fluid loss. Okay, so essentially, what is that? So fluid loss is loss that you have in your ECF compartment. Okay, and it's not a big loss where it needs to be covered in a very small period of time like we do with volume resuscitation. So the difference is maintenance, you give fluid over a longer period of time. Volume resuscitation, you give lots of fluid over a shorter period of time. And you correct big deficits shorter period of time. And maintenance, you're maintaining to make sure they don't lose stuff over a longer period of time. So loss, how do you divide losses? So essentially, if you have a body, this is my body, I eat and drink, so I gain fluid, right? And I essentially take carbohydrates and convert them into fluid, right? C6H12 plus O2 gives me CO2 plus H2O. So I get water from these two sources. So that's my gain of water. And then I'll lose my water through two parts. One I can measure, urine, stool. If I have wounds, if I have a nasogastric, orogastric tube, I can measure that. And stuff I cannot measure. For example, my sweat, or when I respire or breathe, some of the water gets lost there. So what I can measure is called sensible loss: urine, stool, nasogastric, orogastric, and wounds. What I cannot measure, I have to estimate, and that's through skin and respiratory tract. So the goal is my fluid that I gain is intake plus my glucose should be equal to sensible plus insensible loss, right? That should be there. If I am losing more, I need to add maintenance fluid so that my gain equals my loss. Okay? In a perfect world, once the deficit is corrected, when we fluid volume resuscitated. Okay? Now, so that's the two. We are giving fluids. There's resuscitating, which is correcting deficit over a shorter period of time, and maintaining fluids, which is to make sure gain equals loss over a period of time. Then the other reason I can give fluids is I want to give somebody free water. Okay, so again, remember that 5% dextrose? That gives people free water. Doesn't give them calories. So if you have to give calories, you don't give dextrose, but you give them free water. That's when you're giving dextrose, you're telling the world, I'm giving this patient free water. So what's free water? Water free from solutes. No solutes. No sodiums, potassiums, calcium, nothing. What if I have to give a patient calories? Well, there's something called total parenteral nutrition. That's a fluid that's a special solution you run through somebody's intravenous line. And that gives them calories, not dextrose 5%, that gives them free water. And last but not the least, there's a special case. It's called hyponatremia, which is severe and symptomatic. And that's the last case where we run a special kind of fluid for that purpose. So we have about 5 conditions, reasons we give fluid. Okay, so let's examine those in detail. First principle: how do you give fluids? You give fluids by two ways: enteral, or by mouth, or enteral, where it's absorbed through the GI tract. That is the preferred way always. Preferred way always. If they're not super sick and we have a way where we can give it by mouth, we got to do it that way. That's the best way. If not, what do we do? Well, here's their vein. Okay, we put a catheter in their vein and we run an IV solution into their blood. That's what we do. That's what we do. Okay. There's a couple of other ways you can go into their bone and give the fluid there, intraosseous. Again, that and ultimately ends up in the blood vessels or intravascular space anyways. Okay. When we are giving them blood in the vascular space, when we're giving them fluid therapy in the vascular space, what's the biggest side effect to watch out for? Symptoms of increased ECF or hypervolemia or extracellular fluid overload. And check the assessment video where it covers it. Okay? And that's true for all of them. Easy, right? Okay. Now let's go through the 5 things that we require that that the five conditions where that are reasons to give therapy. Volume resuscitation. We are correcting deficits, large deficits in short periods of time. Okay. Prefer isotonic solutions. Why? If you give big volumes of hyper and hypo solutions, hypotonic or hypertonic solutions, what will happen? Huge movements of fluids in and out of cell. Not good. You can kill somebody very quickly if you do that. Okay? So again, when you're volume resuscitating, isotonic is the name of the game. And your two choices are lactate stringer, LR, or normal saline 0.5% solution of sodium chloride. Okay? Again, lactate stringer has 4 milliequivalents of potassium per liter. So you can give it large volume. You don't have to really worry about it. It's a small enough amount of potassium. But if you're giving normal saline, you may cause acidosis. So again, low volume. So again, if it's a resuscitation, it's not as high volume as it is in trauma, then normal saline is the name of the game. Well, why can't we use D5? Remember dextrose, 5%? It's used for free water. So we're going to talk about it later. Okay. Now, the next one is what? Volume maintenance. The goal is what? It's to make sure gain equals, fluid gain equals sensible and insensible loss. Okay? And the goal is to provide the fluid which compensates for patient's tonicity and fluid status. So if the fluid status, ECF, is low, that's when you give what? These fluids to maintain. Okay? Okay? If the tonicity of the patient is high, then there's a propensity to give hypotonic fluid. Remember, this is maintenance. These are low doses, usually run 70 to 150. Low doses, ml/h. Okay? If the patient's tonicity is low, slow, 70 to 150 cc's/h of hypertonic. Again, when the patient is being admitted, labs take a while to come back, so usually started on some kind of either isotonic solution, and if it's maintenance where they're started, then it's the provider's choice. Actually, really doesn't really make a whole lot of difference. Some people prefer hypotonic. Some people like hypertonic, but as close to isotonic as possible. Okay. So for example, you can have half normal saline or D5.5 normal saline. Something. Those are the ones that I've usually seen. And again, it's provider driven. Textbook, again, if you have somebody who's got high tonicity, we'd prefer hypotonic solution. If somebody's got low tonicity in their body, then we'd prefer hypertonic solution. Makes sense, right? That would correct their tonicity. Okay. Next, remember I have to give free water. Which one are we going to use? Tap water by mouth, or we give them what? D5 solution, dextrose 5%. It increases the amount of fluid, yes, but it decreases the tonicity of somebody's compartment, right? This is free water. Okay. The last two are going to be calories. And for giving calories, what are we giving? TPN, total parenteral nutrition. It is hypertonic, very, very hypertonic. It's so hypertonic it's administered through a central line. Because if it's given through a peripheral line, it's so hypertonic, it's going to pull all this fluid in. And that force is going to damage the blood vessels and infiltrate them. I'm giving somebody a bag of nutrition through their blood, right? Man, that nutrition would be real tasty to the bacteria. So, what are some of the issues? Well, that tasty stuff to the bacteria may cause sepsis. So, what do I need to do? Aseptic technique. Very, very careful. Second, the bag and tubing must be changed. Usually every 24 hours, check your facility policy, but they're changed regularly. And then monitor for fever, white blood cell count, or signs and symptoms for any infection. I'm giving them sugar juice straight into their blood. What do you think will happen to their blood glucose? It's going to go high. Monitor their blood glucose. Can you discontinue abruptly? Be very careful. No. Usually patients are put on some kind of by mouth as we are weaning them off the TPN or moving them off the TPN. Okay? Flow rate. Make sure that it's as prescribed and on a pump. Why? Because too fast, you're giving hypertonic solution too fast. What happens if you give hypertonic and hypotonic solutions too fast? All these shifts in the fluid in and out of cell are going to kill the cell. There's a couple of more things. If TPN is being given, it's its own line. Nothing else is given with this drug. So for example, if the drug is hanging, right, and it goes in a patient's IV, goes in their blood, right? We don't want any other drug to mix with TPN while it's going through, okay? And so TPN gets its own line. And last but not the least, there's something called cracking of TPN. So again, you're going to see an oily emulsion on the surface of TPN. If that's the case, the TPN is cracked and the TPN is not good. So that's a time not to use it and or to call nutrition and pharmacy regarding this, okay? So again, that's TPN, total parenteral nutrition. You can also give something called PPN, peripheral parenteral nutrition, though I've seen that not used often at all. This you can give through peripheral IV, and it's not as high, it's not, its tonicity is not as high, and neither it doesn't have all the stuff that somebody needs when they are not able to use their gut to absorb nutrition. Okay, so again, you'd see that in the literature. I haven't seen a whole lot being used clinically. Whenever we've got to do something, we've got to give them TPN, is what I've seen. But again, if you may see it, it's called PPN. You can give it peripherally. Some of the same side effects. It's not got as much nutrition. And again, remember, your nutritionist is your go-to person for fluids and getting an idea of fluids and then also getting an idea for TPN. In fact, most of the physicians just put an order for TPN. The nutritionist is the one that generates all of that stuff. Okay. Last but not the least, remember the exception, the fifth exception, which is hypertonic solution, which is given, which is 3% normal saline, 3% NS, which is given in severe symptomatic hyponatremia. This is what I call an exception to the rule. It's a very slow infusion given in an ICU setting. What is this hypertonic solution going to do? Oh man, it's going to increase the osmolarity of ECF. What is that going to do? Oh man, it's going to pull all this fluid out of the cell. So if somebody's hyponatremic, right, they've got the opposite problem. Okay? So I got to correct that sodium in the ECF. That's why I give this solution. The problem is, if this is done too fast, those cells the water moves out too quickly from the cells, right? Because let's go through this again. Here's the cell, right? If I have hypertonic solution, which is being given, lots of sodium here, which is going to pull the water out. When the water is pulled out, the cell will shrink. So usually it's given in the settings of hyponatremia. So the cell is already swollen up. So usually when you shrink it, the goal is to get it right. The problem is if you do it fast, if you do it fast, the cell uh, gets injured because of rapid uh, shrinkage, if that makes any sense. Even though it's shrinking to the right side, this rapid shrinking actually causes the cells to get damaged. And what one gets is something called osmotic demyelination syndrome. It was called central pontine myelonalysis. Oh, I didn't say that correctly, but osmotic demyelination syndrome. Thank God they came up with a different name. So it's irreversible neurosymptoms 2 to 6 days after their sodium is corrected, and you basically have paresis, which is, your the extremities have weakness, dysarthria, dysphagia. You can become quadriplegic, lethargy, confusion, coma. These are mental status changes. Last but not the least is locked-in type syndrome. What does that mean? That means patient is aware they can't move any of their extremities. They're able to breathe, they can feel everything, they just can't do anything. It's a very um, severe side effect of this therapy. It's a very dangerous therapy. We do it in ICU. It's corrected very, very slowly at 0.25 milliequivalent per deciliter per hour of sodium. And it's done very, very conservatively in a very rare circumstances. Okay, so let's go through this one more time. Got to give somebody fluids. Well, I got to know what I'm giving them. Is it hypertonic, hypotonic, or isotonic? And we talked about common solutions, what their tonicity is. We talked about isotonic, hypertonic, and hypotonic solutions. We also talked about how I can give you a new solution and you can, well, pretty much figure out whether it's isotonic, hypotonic, or hypertonic. We talked about 5 reasons for giving fluids, right? Which is amazing because that actually helps us figure out everything. Which is, these are the 5 reasons. I got to resuscitate their volume. I got to maintain their volume. I got to resuscitate volume. Large amounts of fluid, correcting deficits over short period of time. Fluid maintenance, making sure on a longer period of time gain equals loss. Free water. Calories. And last but not the least, there's an exception which is giving hypertonic solution of sodium, 3% sodium for hyponatremia, which is severe and symptomatic. Resuscitation, we talked about lactate ringer, trauma for everything else, which is not as high volume. If you're giving 20 bags, 20 liters, you want to give lactate ringer versus 2 or 3 bags, then normal saline would be fine. And what the differences between the two therapies are. With maintenance, take your pick. But the best one is therapy that complements um, what the patient's fluid volume, what patient's tonicity is. Their ECF is going to be down. That's why you're giving them volume. Their fluid status is going to be down. But what would determine would be their tonicity. So if a patient is more hypotonic, then one may prefer giving hypertonic maintenance fluids 70 to 150 ml an hour and vice versa. Again, free water, we talked about D5 or tap water. And then calories, we talked about total parenteral nutrition. And then last but not the least, we talked about that one case where we gave this 3% normal saline hypertonic solution in ICU, otherwise it causes osmotic demyelination syndrome.